Very good morning to everybody. We are starting with the arena of radiology. This is Dr. Salma Parvin, Assistant Professor and Head of the Department, Radiology Imaging, Faridpur Medical College. And she is from Dhaka Medical College K45 batch. That means MBBS is by 1995. Department of Radiology is going to deal with the topic of acute abdomen, the medical emergency situation with sudden severe abdominal pain of more than 6 hours, or somewhere it is written as less than 24 hours duration and requiring urgent specific diagnosis and care. Now, why we have chosen acute appendicitis as a first topic to be delivered? Because acute appendicitis is a major cause of everyday hospital admission, the commonest cause of acute abdomen in young adults, and also the appendix is the commonest site of carcinoid tumor. We put a preference on this very admission encounter. The vermiform appendix is a blind tubular structure, the base of which is along the confluence of the tinea coli at cecal dorsomedial aspect. Only noted in humans, the lucky human beings to enjoy such vestigial body. Before the story begins, we should warm up with the anatomy. The specialty contributed in the appendix are: the length is between 7.5 to 10 centimeter. The columnar mucosa is outlined the interior, producing longitudinal mucosal folds along the cavity. Few crypts are seen with argentophyne cells along the bases of the crypts. And what is the clinical features here? We can go through quickly. The periumbilical colicky pain that shifts to the right iliac fossa. The fever ranges from 98 to 102 degrees Fahrenheit, nausea, vomiting, diarrhea, and sometimes intestinal obstruction. The necessary investigations are like urinary, X-ray KUB, pregnancy test, CVC, ultrasonography, contrast CT abdomen, and the interpretation you can go through like this. The urinary can give you the presence of either the renal or vesical calculus or cystitis, any sort of inflammation or RBC present in urine. The X-ray KUB can exclude the renal colic and presence of a renal or ureteric stone. Pregnancy test is necessary because the right iliac fossa is also harboring the right adnexia, which can be a part of ectopic pregnancy, sometimes mimics the acute appendicitis like features. And CVC provides you what you know that gives you the idea about the presence of an inflammation. The state of inflammation also can be gone through, like the WBC count more than 15,000 implies to definite gangrenous perforation of the appendix. What about ultrasonography? The easily available method can give you a destination of presence of acute appendicitis, And contrast CT abdomen is very much definitive and superior investigation for the decision of acute appendicitis and its complications. And what about plain X-ray? The first investigation called in acute abdomen is simply a plain X-ray. Then what is its value in declaring acute appendicitis? You should know that the value is basically limited. It is applicable in detecting only the free gases to be seen under the hemidiaphragms if there is appendicular perforation. And of course, detection of appendicular is very important feature can be here, so that a suspected case of acute appendicitis has a possibility of 90% chances to have acute appendicitis. There are sometimes features of small bowel obstruction pattern of gut dilatation in 40% cases. So this is a plain X-ray abdomen that is showing a roundish radiopaque shadow along the right iliac fossa, giving the impression of appendicular. And what about the role of ultrasonogram in acute appendicitis? Ultrasonogram gives you an accuracy of diagnosing acute appendicitis of about 97% sensitivity. This is easily available. No non-radiation hazard made it much closer to the field of diagnostic arena. At a time, it claims a very meticulous evaluation and expert in the field. Two important terminology here. One is graded compression and a superficial probe. Why a graded compression and why a superficial probe is part of a special evaluation technique here. We will be able to learn later on. And the ultrasonographic findings we get is a peristaltic, non-compressible, blind loop, dilated structure, more than 6 millimeter in outer diameter, and is attached along the posterior aspect of the C curve. Sometimes fecolith and appendicolith we can see very clearly, and the distinct appendiceal wall layers because of the edema and the echogenic pericecal fat and periappendiceal fluid. This is the sonographic depiction of acute appendicitis. This is a normal ileum entering to the back. The end-on photograph of an appendix, and this is the appendix, has got a comma-shaped appearance showing the outer serosa to be reflected and echogenic, and you see some omental edema that is called omental migration around, and here is seen, and also here it is noted. So this is the early feature, early acute appendicitis seen in this photograph. Another acute appendicitis is seen. This appendix is edematous and has got fluid around the tip, and there is distinctive layers seen here. The serosa is here separated from the wall, and the accumulation of fluid you can see along the tip. And this is the appendix, has got the inner layer and outer serous layer in between the edema fluid is running. This is the end on target sign is said that edema around the inflamed appendix and inner walls are echogenic. And this is the appendicular here in a dilated fluid-filled appendix. I just want one thing to be mentioned here, that this is a convex probe. This is an abdominal probe. And you see the other slides here has a flat surface. This is called the superficial probe. It was applied here, so that these are the millimeter structures we have to define. You know that we have to define the walls of the appendix by 2 millimeter or more. So it needs a more closer vision and more optimum evaluation of the surrounding structures. And superficial probe can go through the millimeter level of study, but what about the abdominal probe? It runs for the centimeter study. So if you get a very much dilated appendix, a large appendicolith and ficolith, you can go through the abdominal probe and you will see it. You can have it a look. But if you try to assess this appendix, a small appendix of millimeter value, you must miss it. So the application of superficial probe and what is graded compression. What is graded compression really? You know that whenever there is appendicitis, the right iliac fossa is tender, and there is a accumulation of the gut loops in the RIF. You know, the largest dimension cecum is full of air and fluid from the ileum. So there is a large pouch of air there. Also terminal ileum is there and small bowel loops roaming around. So the inflamed appendix is really hidden by these air structures, and you need to deviate all these airs gradually. So you met gradual compression and C and compression, and gradually you compress and gradually you will be able to see. This is called graded compression. And this is a large appendicular abscess. It would be because there is a dilated structure, there is edema around the appendix and the fluid here, and there is a definite obstruction seen here, causal obstruction is seen here. So there is distal accumulation of inflammatory fluid that is called appendicular abscess. And what is the role of CT in determination of acute appendicitis? CT is basically superior modality in detecting acute appendicitis and its complications. Sensitivity is really the same of 97% for the ultrasonogram and CT. CT findings of acute appendicitis are dilated appendix with a diameter of more than 6 millimeter and the wall thickness more than 2 millimeter. There is adjacent mesenteric fatty stranding, mesenteric adenopathies, appendicolith, and periintestinal fluid. Sometimes you can get only the increased diameter in CT scan. That is the early finding. You can detect by CT scan. The CT image you can see here that there is a rounded structure, enhanced rounded ring lesion here with a ficolith at a wall attached, and there is, you see the edema, and the mesenteric edema is around. The mesentery has been drawn and there is fluid around. So this is the prototype of the CT image can detect and declare acute appendicitis. Very clearly seen, and at a glance you can detect, yes, there is acute appendicitis. The same patient has got, this is the dilated appendix, fluid around, and the radiopaque part is here at the tip of the infant appendix. You can see something else is here, different from other parts of the content in this pelvis. There is a gut loop full of air and fecal matters. And what is fecal matter? You can come to conclusion both in X-ray and CT scan is air mixed with fecal matter is the presence of feces is seen in the large gut. It will not be seen in the small gut. Yes, you can get it in the small gut. Whenever there is intestinal obstruction, there is different thing, not for you really. And this edema you can see here. What is the next slide? Yes, at the down slide, we can get a curved structure here. And there is a radiopaque structure here, fecolip, and you see a small air pocket here within this edematous omental gathering. That is not part of this one. This part has been smashed into this omental edema because this is featureless. Like consolidation, you can compare that it is featureless. You cannot see anything. There is edema here, the curved appendix here, at the tip of which is a fecolip, and there is really a rupture of the appendix. And we can go for a small comparison of the ultrasonogram and CT in these two slides together. This is appendicitis seen in the abdominal probe. That means the appendix is really has got a value of centimeter. So abdominal probe has been used, and the appendix is here bulged into the RIF, and surrounding fat stranding, there is edema around. This is appendix. So the visible appendix with edema and surrounding fat gathering, omental gathering is the simply declares there is acute appendicitis sonography. And what is seen in the CT scan? There is also omental migration and edema here. Fluid is seen here and around the structures here, and there is small pockets of early perforation seen along the wall of the infant appendix. So the complications of acute appendicitis is better seen in CT scanner. That takes really minimum time to declare, but you can also declare in ultrasonogram, but it takes more time, more expert you need, and but the sensitivity is the same, but CT scan is superior to declare the complications, and its 3D relation to the other structures in the pelvis. Next, there are some peculiarities we have said about the clinical features of acute appendicitis, but you can go for the other special patterns of appendicitis presentation. The retrocolic and retrocecal has got 75% of the appendix anatomy. That appendicitis produces symptoms of local tenderness and irritation. The symptom is local. What about the subsequent and pelvic type? It has got urinary symptoms whenever it relates to the urinary bladder, and diarrhea when it is pelvis and irritates the rectum. And about pre-ileal and post-ileal, it presents with diarrhea and vomiting of intestinal obstruction type. The other causes of right iliac fossa pain, you can go through the uretary colic, the cystitis, salpingitis, euphoritis, local adenitis, and cecal pathologies, you know. Sometimes we declare that appendicular lump has been developed and patient is deferred not to be surgery in now time. Patient is asked to with antibiotics and sent to home that let the lump resolve and come again. So what is this appendicular lump? Is formed after acute appendicitis and the resultant rupture and perforation of the appendix is walled off by the omental abdominal policeman, you know, and the lump may be inflammatory mass with appendix, adjacent viscera, and greater omentum, or a pus containing appendiceal mass. This is the appendix, you know, there is perforation, the accumulation of fluid here. The hyperemia seen around the inflamed appendix, the superficial probe has been used here, you know. And this is appendix here, the appendix, inflamed appendix is running here as a worm, and there is a dependent accumulation of abscess fluid and the omental migration walled off it. So this is appendicular lump. And the carcinoid tumour is also a place, appendix is its common involvement. And what is happened here? There is no inflammation around, there is a mass inside the echogenic lumen. The solid mass in the echogenic outer wall, calcification, no much surrounding inflammatory reaction. You see, there is no omental migration much here. And finally, this is the normal appendix. We have started with the anatomy of normal appendix, and we are closing the session with this photograph of a normal appendix. Usually we are not customized to find out a normal appendix, and usually it is said the normal appendix is not really seen. Yes, you can be able to see in CT very easily with the ultrasound with difficulty, but you need not to search this normal appendix, because this disease, without disease, it has got little value in clinical context. So thank you, Axis Medical School, for giving me opportunity to convey my lecture here. Thank you, everybody. If you have any question, then you can ask me.